Hi, class. Vivian here. It's nice to finally meet you in person. So today my talk is going to be about something. Oh yeah, memory. So what do concepts in this chapter mean for counseling? And I think there was another part. Oh yeah, how do they relate to Alzheimer's? I've also included something else that's very special in this presentation, but I don't quite remember what it was. Anyways, I hope that you do enjoy the presentation, that you find it a meaningful contribution to the course. I look forward to your questions and comments at the end of the presentation and hope that you can stay vigilant in paying attention throughout the presentation. So thank you in advance. So here's an overview of what I'm going to be discussing today. An overview of memory and memory impairment, followed by an overview of Alzheimer's disease and the implications for counseling. Then I'm going to discuss about trauma and fear conditioning, which are very important and relevant, and the implications for counseling with that as well. And then, of course, I'm going to end with some concluding remarks. So I hope you enjoyed today's presentation. So what is memory? Well, if you Google it, it says memory is the faculty by which the mind stores and remembers information. If you look at Bannock and Compton's definition, they state that it's a group of mechanisms or processes by which experience shapes us, changing our brain and behavior. And I also like to include this quote by Edward de Bono that says, "A memory is left when something happens and does not completely unhappen." So we've learned a great deal from neuropsychological and neurophysiological studies about memory, particularly from amnesic patients. A lot of these patients have sustained brain damage, either from surgery, accident, or illness. A good example is the case of HM that's discussed in the text, where HM received total removal of the medial temporal lobe in a surgery to help with his epilepsy. This, of course, left him with a devastating case of amnesia that has been studied for over 50 years and has contributed a great deal to this field of knowledge. So from the study of HM as well as others, we have been able to identify that there are several different types of memory, and that these different types of memory are mediated and stored by different circuits and structures in the brain. Damage to these specific circuits and structures can produce specific types of memory impairment. So let's talk about the different types of memory. Well, we have explicit memory, or otherwise known as declarative memory, and this is the conscious recall of prior experiences and facts. Then there's also implicit memory or procedural memory, which is the unconscious memory of how things should be done, or skill learning. There is, of course, working memory. And also, we're going to have a special discussion later on in the presentation about fear conditioning, trauma, and emotional memories, as they are of particular importance to counseling. Explicit or declarative memory, so this is conscious memories that we have conscious recall of prior experiences and facts, include episodic memory, which is autobiographical memories that are specific to our own particular experiences, and they include context that includes information regarding the time, the space, etc. Then there is semantic memory, which is our memory of facts, concepts, categories, word meanings, and the retention of information about ourselves and people we know, characteristics, things like that. Both these memories are mediated by the medial temporal lobe, especially the hippocampus, and the anterior temporal lobe region seem to be particularly important in semantic memory. The hippocampal system, importantly, supports relational learning. So that is the acquisition of memory or of the relationship between items, especially those that are related arbitrarily or accidentally. So it allows one to remember the relation between different pieces of experience or events, whether this is conscious or unconscious. Hippocampal cells also exhibit various interesting functions that are important for memory functions, such as LTP, long-term potentiation current, as well as the ability to act as place fields. And so, while the hippocampal system is extremely important to supporting conscious memory, it's important to know that consciousness does not rely on the hippocampal system. Implicit or procedural memory is also called skill learning. So this is the unconscious memory of how things should be done. This kind of learning occurs gradually and incrementally through the repetition of motor, perceptual, or cognitive operations, leading to improved performance. So this is kind of learning or memory is independent of the hippocampal systems. And the memory is often stored in the same brain regions where the information was originally processed. So it is domain specific, such as in the visual cortex, auditory cortex, or somatosensory cortex, for example. So an example would be that damage to the ventral visual processing stream that supports visual object recognition can also result in visual agnosia. This is a condition where individuals cannot identify previously known objects or learn visual forms. So this type of memory relies on reactivation of the same domain-specific regions of the cortex that were originally activated during the processing of the event. The basal ganglia has also been implicated in skill or habit learning and is particularly affected in Parkinson's disease and Huntington's disease. This is a disease where procedural memory is highly affected while sparing explicit or declarative memory, and this pattern is opposite to that found in Alzheimer's disease. Working memory is the ability to hold a limited amount of information online over the short term while it is being actively processed. This kind of memory is highly dependent upon domain-specific processing systems, such as the auditory verbal working memory, as well as the visual spatial working memory. The prefrontal cortex is also involved in executive processes that act on information in working memory, such as selecting the most relevant contents and manipulating information. There are three main important processes in memory. That is that of encoding, and then consolidation and storage, and retrieval. The hippocampus and prefrontal regions have been found to be important for encoding, and the hippocampus binds together different attributes of the events, whereas prefrontal regions likely aid in focusing or organizing the encoding process. The hippocampus is involved in storing the information for a period of time and indexing where in the cortical processes discrete aspects of the event are stored. Prefrontal regions assist with retrieval by aiding the search process as well as selecting the most appropriate information. And the left parietal regions are implicated in recognition memory and in judging familiarity. So let's talk a little bit about memory impairment, specifically amnesia. So amnesia occurs after damage to the hippocampal region or the midline diencephalic structures, such as the dorsal medial nucleus of the thalamus and the mammillary bodies of the hypothalamus. This can result in anterograde amnesia, which are deficits of learning new information after the damage has been sustained, and or retrograde amnesia, which are impairments of memory that were acquired prior to the damage. Often observed with retrograde amnesia is what we call a temporal gradient. So that means that the memories that are most resilient to damage are often the oldest memories, whereas the newer memories are often more vulnerable. This suggests that memory may undergo change during time, making it more resilient to damage. Amnesic patients often display long-term memory deficits with spared working memory and procedural memory. Alzheimer's disease is a cortical dementia, also known as dementia of the Alzheimer's type. It is defined by a decline in memory as well as other aspects of cognitive function, including at least one of the following: language, visual spatial skills, abstract thinking, motor performance, and judgment. Emotional dysfunction and personality changes are also usually present, and they may become profound along with progression of the disorder. The brain damage in Alzheimer's that is sustained is often diffuse throughout the cortex and involves a variety of structures. The neuropathology of Alzheimer's is characterized by neurofibrillary tangles as well as beta amyloid plaques. And there are generally two types of classes of Alzheimer's disease, which is early onset that occurs below the age of 65. in which we often observe a faster decline, and late onset of Alzheimer's disease after the age of 65, which is usually characterized by a slower decline. Alzheimer's disease is characterized by a number of deficits, such as global anterograde amnesia, which is the inability to form new memories, and progressive retrograde amnesia, so previous memories fading fast as the disorder progresses. However, procedural and implicit memory is often left unaffected. But Alzheimer's disease does display several progressive cognitive deficits, such as aphasia, the loss of ability to understand or express speech, particularly involving semantic aspects of language more than syntax or phonology, agnosia, the inability to interpret sensations and to recognize things, apraxia, the inability to perform particular purposive actions. So this affects more the conceptual aspects of motor behavior. And alcalcula, the loss of the ability to perform simple arithmetic calculations. For tables detailing these major characteristics distinguishing cortical from subcortical dementias, as well as the typical rating scales of Alzheimer's disease concerning its progression, please refer to page 474 and 475 in Compton and Bannock's text. Genetics and neurotransmitters. Early onset AD, which occurs in less than 5% of patients, has been linked to mutations in presenilin 2,1, trisomy 21, and amyloid precursor protein, whereas late onset AD has been linked to the ApoE gene, which codes for a protein that is thought to play a role in clearing amyloid plaques. ApoE4 has been associated with an increased risk for AD, whereas ApoE2 has been associated with a decreased risk for developing the disease. The cholinergic system is severely compromised in individuals with AD, and the degree of this disruption correlates with the severity of dementia. In fact, the main route for cholinergic input in the cortex and the hippocampus is lost, with up to 90% of cells in the nucleus bacillar of Maynard being destroyed. Acetylcholine is important for attention, learning, and memory. ACS agonists have been shown to increase activity in extrastriatal regions during working memory tasks, whereas ACH antagonists have been shown to induce deficits in learning new tasks. These deficits are comparable to those seen in older individuals, and they can also be reversed by agonists of ACH, such as physostigmine. Noradrenergic and serotonergic systems are also compromised in AD. And reductions in levels of glutamate and dopamine have also been observed, but to a lesser extent. Due to the fact that the cholinergic system is so severely compromised in AD, pharmacotherapy through acetylcholine esterase inhibitors is often the treatment of choice. Inhibiting acetylcholine esterase, which breaks down acetylcholine in the synaptic cleft. Memantine is another drug that is often used, and it blocks NMDA receptors, which reduces the neurotoxicity that is induced by excess levels of excitatory amino acids in Alzheimer's disease. These drugs can slow the course and progression of the disease, but they do not stop it, nor do they directly address the core pathology of the disease, such as the amyloid plaques or the neurofibrillary tangles. Therefore, prevention is key by addressing lifestyle factors such as diet, exercise, smoking, and the degree of mental activity, all of which have been shown to be contributing factors in the generation of Alzheimer's disease. So what are the implications for counseling? Well, caregiver assistance is essential in individuals with AD. They need help with driving, traveling, handling financial matters, dressing, planning, etc., and oftentimes they need supervision later on as the disease progresses. Studies have found that early detection and counseling for both patient and caregivers can improve quality of life for the patient and prevent distress and negative mental health effects for the caregiver. Counseling for caregivers can also significantly prevent and delay admission of loved ones to nursing homes. In fact, a study reported that 66% of adult caregivers in the control condition, so those who did not receive counseling, admitted their parent to a residential care setting, compared to only 37% in the treatment condition who received counseling. And those who received counseling and who admitted their parents, on average admitted their parents 228 days later than those who did not receive counseling. Delaying or preventing admission to long-term residential care programs has been reported to be able to save up to $41,000 per year per patient. So counseling in AD patients and caregivers improves quality of life and also saves money. Counselors with knowledge of AD risk factors can make early recommendations for prevention with their clients as well. For a review of recommendations for the diagnosis and management of AD, please see Waldemer, 2006. So let's talk about now the incredibly important role of memory in fear and trauma. The amygdala is an incredibly important structure for fear conditioning, to contextual fear conditioning, and the acquisition of emotionally charged memories, such as those in trauma. The amygdala mediates learning and expression of emotional responses to stimuli, whose emotional significance is not automatic, but has been learned by association, such as in fear conditioning. The amygdala allows emotional experience to modulate certain aspects of long-term memory, such as in trauma, where there is a selective enhancement of recall for the emotional component of a memory, such as in a tragic story or accident. Bilateral removal of the amygdala, such as in the case of HM, results in a decreased ability to access information about internal states, such as to be able to assess or identify painful stimuli or ascertain hunger. Bilateral damage of the amygdala can also result in an inability to learn, provoke, or even feel fear, while leaving other basic emotions intact, demonstrating the amygdala's tremendously important role in fear, trauma, and the memory of these traumatic and fearful emotions. Studies of PTSD and trauma show that there is an increase of noradrenergic activity during life-threatening events, and that this may contribute to strengthening or over-consolidation of the memory for trauma, and that the lateral nucleus of the amygdala is critical for fear learning. A distinct pattern of the anterior cingulate cortex, the ACC, and amygdala connections has also been observed. So patients with PTSD show a marked bilateral reduction in the medial prefrontal cortex, and particularly in the right ACC, and a significant enhancement in the left amygdala activity, with a reduction in early right amygdala response, as compared to non-traumatized controls, when exposed to consciously processed fear stimuli. Furthermore, a core feature underlying physiology in major depression is a heightened amygdala reactivity to aversive stimuli. Furthermore, childhood trauma and risk for depression is mediated by a heightened amygdala response. In fact, there is a robust positive correlation between a history of physical abuse and right amygdala response. Other studies have also shown that the configuration of brain networks associated with the amygdala may be linked to trauma symptoms even in healthy adolescents. A recent study showed that increasing self-report of trauma symptoms was associated with increasing functional connectivity with the right amygdala and a local limbic structure, as well as decreasing functional connectivity with the left amygdala and a long-range frontal parietal region. This can also be a hallmark of immaturity. Importantly, emotional trauma can be transmitted across generations. In an interesting rat study, it was shown that early maternal fear cues can induce an amygdala-dependent learning plasticity change in the offspring. So rat pups exposed to mother's conditioned fear resulted in mother-to-infant fear transmission, mediated by activity changes to the lateral and basal amygdala nuclei in the pups. This activity could also be blocked by pharmacological inactivation of the pup's amygdala, preventing the fear transmission, and showing that the changes in the amygdala were key for fear transmission. In another interesting study, it was shown that mothers' unresolved trauma can lead to disrupted maternal caregiving, mediated by a blunted amygdala response. And mothers with unresolved trauma displayed a blunted amygdala response when cued by their own infant sad faces, as compared to controls who had no trauma, who demonstrated a greater amygdala response to the sad faces of their infants. So what are the implications for counseling? Well, exposure therapies, otherwise known as depotentiation therapies, are effective at removing fear conditioning and traumatic memories. They utilize a natural mechanism of the brain to remove the material basis for the fear memory. they depotentiate glutamate receptors on synapses mediating the fearful traumatic memories in the lateral nucleus of the amygdala. Depotentiation therapies work by extinguishing the emotional aspects of fear memories. There are fast depotentiation therapies, which involve repetitive sensory stimulation, such as EMDR, eye movement desensitization reprocessing therapy, EFT, emotional freedom technique or tapping, TFT, thought field therapy, and there are also the standard depotentiation therapies that take a longer period of time, and these are traditional exposure therapies such as behavioral therapy, flooding therapy, and exposure therapy. So the formation and retention of fears and traumatic memories is dependent upon the amygdala's involvement in memory, and the emotional aspects of these fears can be extinguished by using the mentioned depotentiation therapies. Many clients of yours will present with fears, conditioned fears, as well as traumatic experiences. This is often the case with depression and anxiety. Therefore, it is important to treat these fears as well as resolve trauma, both for the client's well-being and for their offsprings. So to conclude, memory is a highly complex function of the brain. There are different types of memories mediated by different brain structures and functional circuits. Neurophysiological studies have taught us a great deal about how memory functions in the brain, as well as what happens in memory disorders such as Alzheimer's disease. Studies have also shed light on how the brain processes and accumulates fears and traumatic memories, and research has elucidated numerous strategies for intervention with various counseling approaches, both in Alzheimer's disease, caring for the patient and the caregivers, and for individuals suffering from fear and trauma. It remains important for counselors to be aware of the biological underpinnings of their clients' disorders and concerns, and to evaluate them within the biopsychosocial context of their client's situation. So good luck, counselors. We certainly all have our work cut out for us, but I think we're up for the task. Good luck with the rest of the course and the rest of your program, and I look forward to seeing your questions and postings in the board.